information, and it turned out that the old coronavirus responses were mostly not about antibodies. Antibodies were weak, insensitive, and they didn't last. So the first SARS, which was 2003 or something, there was nobody who had antibodies after 3 years, but 17 years later, everybody who was measured who survived it had T cells. So it seemed as though coronavirus was better at making T cells than at antibodies. It also is the truth, and this is also true for COVID-19, that the higher antibody you have in acute infection, the worse sick you get. Now, that doesn't mean they're making you sick, but it means that they're not protecting you. Whereas the higher T cells are associated with doing well. So it seems though in acute infection, it's the first time you've ever seen it, so you don't have an antibody to keep it from cells. T cells keep you alive. They're the ones who do the job. Now, I won't say much about what this fear that we had that antibodies can cause worse disease, called enhancement, because it so far hasn't proven the case with this coronavirus. And I was worried about it, but so far we have no evidence for it. Okay, so let's then move on to, I think, the punchline, which is what we do and do not know about COVID-19. And we can talk about natural infection, and now we can talk a little bit about vaccination. We do have a few months of experience here. So not everybody, but almost everybody who gets COVID-19 gets antibodies, maybe 90%. If you have a very mild case, sometimes you don't get it. But here's the key point. I'm going to come to this over and over. The half-life of these antibodies is not years. It's months. It's 2 to 4 months, let's say. And if anybody knows anything about investing or paying interest, you know that the exponential rule really adds up. So if you fall by half every 3 months, we can do the math, and that means that after 6 months, it's a quarter. After 9 months, it's an eighth. After a year, you're down to 1/16 as high levels as you had. This is a real concern we'll get to. This is what I'm afraid of. Now, T cells are also observed in natural infection. They are not mostly against spike protein, which is an interesting worry because the vaccine is entirely against spike. We also don't know how long they really live. I'm working this myself a little, but the half-life is probably in the same order, 3, 4, 5, 6 months. Again, that is not years. That is not decades like yellow fever. And memory B cells are one exception. Memory B cells are sort of our reserve antibodies. And they seem to be lasting a while at least a year. They're not dying away at all. But we don't know much about it. So this is an example of, you'll see a figure like this occasionally. This is antibody titers after natural infection. You say, oh, that looks pretty good. But then if you look closely, you see it's a logarithmic scale. It goes from 160 to 80 in 3 months. That's falling in half. This is not a long half-life. We really have to attend to this when we think about the future. Okay, now this is another point. We're talking about mutations. It wasn't sure, but it is now certain that some mutations, particularly like one at the position 484, it turns out, can really resist neutralization by antibodies. Here's a figure where you can see at day 30, which is still early, this is the dilution, how much blood it takes to neutralize, the ability to resist the dilution compared to a control of a natural virus, a non-mutated virus. And you can see here for this particular mutation, it is 100-fold less sensitive to neutralization. And this is maybe a hard figure to read, but just the punchline here is that this virus, mutated 484, is 100 times less sensitive than the natural unmutated virus of SARS-CoV-2. And so now we have to think about what happens when viruses become more mutated and antibody levels are falling. That's the combination that is of concern. So let's move on to talk about vaccination. Again, what I was just talking about here was natural infection. I'll focus on RNA, mRNA vaccinations. The Pfizer and the Moderna are getting the most publicity, and they've been a great relief. It turns out, and nobody knew this was going to be true, we are really lucky. The antibody responses are as good as or better than natural infection. The lifespan is similar to natural infection, which again is months. And the mutants are less sensitive to our antibodies after vaccination. So why have we not had people getting so infected? And the answer is just arithmetic. We have a very high neutralizing capacity with these vaccines. And just to give you some numbers without knowing the details, let's say we have 1,000-fold excess capacity to neutralize. So that sounds great. You only need 20-fold to really be protected. So you have all this what looks like this leeway. But if it's falling by half every 3 months, and if some mutants are now 10 or 100 times less sensitive, you can see how the lines would cross. There may be a point where suddenly the mutants are no longer neutralized because the titers are not as high. And we'll get to that, I think, as a punchline. So the T-cell response is not as well characterized, but again, as I said, it must be present because people are getting sick but not dying, and T-cells are the only explanation. It seems to be not as responsive for T-cells after the vaccine as after natural infection. But we don't know much, and the durability is also uncertain. Again, memory B-cell response is a big question. We don't know much at all, and I really like memory B-cells, as we'll get to in a minute. So, if people can ask questions now, or I can go through the, I think the unknowns that we have. Maybe I should just do that for a few more minutes.
Yeah, I think you should power through the unknowns, please.
Okay, great. So this is a list of them, and sort of everything is unknown. We don't know how long or how effective the antibodies in the blood will be, or the memory B cells, which is sort of backup, or the T cells. Will it require booster shots? Will there be better vaccines coming down the pike? Will this protection differ for different groups, as we are highly aware of as clinicians that have different risks, like older people, diabetic, cardiovascular disease? And what can we know quickly? So again, to me, these are linked questions, durability and resistance, because if you're not durable, you become more resistant over time, and viruses will mutate, and they will become harder to neutralize over time, just as we're losing protection. So neutralizing antibodies are falling. There's no question. Half-life of months. As I said, these high levels are what are protecting us now, even against mutations. It's like having money in the bank. But as we lose these titers, some mutants could very well escape. Memory B cells could be a solution. If we have better antibodies working in our bone marrow that'll come out with a repeat infection, that would be great. But we don't know if that's the case. And in fact, there's reason to believe it might not be, because will antigens persist in our body? This is a technical point, but to get these improved B cells, you need to have antigen in your body, and that's true after an infection, which gets in tissues. But after an RNA vaccine, there's no data on it, and there's no reason to believe that will be the case. So we're worried. I think it's speculation that we'll have good memory B cells. And T cells, again, even if you get infected, if you have T cells, you're not going to die. And so again, T cells are a very important part of the whole story, and we don't know the durability of T cells. And maybe I get a little redundant here, but some of these questions are, what will happen? When will viral mutations start to break through as titers fall? Or will memory B cells step up? Now, you listen to really great people like Tony Fauci who talk about getting booster shots. I don't know what it's like in LA, but do you think everybody in LA is going to line up for a booster shot every 2 years for the next 30 years? I just have trouble with that. I don't think Americans do anything. And I think if that's our goal, if that is our strategy, I really have fears about that. It leaves me feeling vulnerable. Now again, maybe T cells will step up, but we don't know how long they live after vaccines, and we don't know how well they protect against mutations, although they should do well. T cells are really our magic trick in the book, because they have very great breadth against all parts of the virus. You can't really mutate your way around a T cell. This is data that I generated, but we don't need to go into that. So I think, just to sort of summarize, we need to know, in terms of vaccinology, I'm not sure if that's the main concern of this commission, but can we make better vaccines? Can we do adjuvants? Can we target more than one part of the protein? But and will the vaccines differ in clinical risk groups? But here's let me close with these last couple slides. My view is we need a great vaccine. I think the idea of, that's just a personal take. I think a vaccine to be a great vaccine, has to last a long time, and it has to provide protection against the inevitable mutant. It has to prevent serious illness, which means T cells. And I think it's unrealistic to expect everybody to repeatedly get booster shots. I just don't buy it. Maybe we could pull it off. So I think from the point of view of biology, this means that a vaccine should generate long-lived T cells and affinity matured or improved B cells, and we don't know that this is the case. I do believe I'm very grateful for this lag we have in a international crisis, but I don't think the work is done, and I don't think these vaccines will be the ultimate vaccine. But I don't know what will be better. And if I were to summarize the broad picture, I've thought for years that vaccination is the greatest discovery in the history of medicine. I don't think we would have our interconnected world if we were having smallpox breakouts every 5 years around the world. But to depend upon antibodies that are not long-lived, they could be evaded by mutants, leaves me feeling vulnerable. So I think we need vaccines that are as good as a smallpox vaccine, that last for your whole life, and that engage the entire immune system. We don't know a lot about this, so I feel like there's a lot to do. Now, where does that leave? Oh, this is just my picture. This is Elvis getting a polio vaccine in 1955. And I feel like that's what we need. We need a vaccine that everybody will line up for, and that will, really be will last us. You get one polio vaccine, and that's all you need. So I'm happy to open this up to any questions you have, including what we might do in a public health sense, given these concerns.
Great, wonderful. What I would ask is, and I'm not sure, I think everybody can raise their hand so that I can see that. But I'll take the chair's privilege of asking two questions first, and then Vice President Grimmig has a question. So if I could go first, Dr. Hellerstein, we know that, as you mentioned, that with SARS, which was already 18 years ago, that places that had high infection with SARS and have a lot of individuals who have documented T cells, such as Singapore and Taiwan and Hong Kong, had much less initial infectation and spread of the disease a year ago spring, when it was traveling across the country, those countries. So the question would be, clearly there's some cross-protection with SARS, and now that we have T-cell response here directly to COVID-19, can we not imagine then that we should have protection for a decade or two if we have a good T-cell response? So that's the first question.
That's a great question. And when it first came out, I was really amazed and thrilled by these the data that 30 to 50% of people in various, and it was also not just Asia. It was also in San Diego. So it wasn't SARS, first SARS. It was coronavirus cold. What people think. It was the idea that if you had a cold, a coronavirus cold in the last 3 years, you would get T cells and you would be protected against this lethal illness. I thought that was crazy, interesting. And I think it's true. There's a lot of cross-reactivity for T cells against all coronavirus. Now, the difference here is that those were natural infections. And the T cells against the first SARS, as you mentioned, are there 17 years later. And so they could have helped, or it could be that some people just had cold, which is so almost hilarious to get protected by having had a cold. And but I don't know that that's true against the vaccine. We have 30 million people who got, or something like that, who got in America, who got COVID, and we are going to have 200 million who got the vaccine. So I would love to see that, but I don't know how good those T cells are going to be. But that's a great question. But that's the question: how good are those T cells going to be? How long are they going to last?
Okay, and the second question is we know that certain lifestyle activities improve our immunity or sometimes hurt our immunity. Is there any studies done on anything that we could do to boost our T-cell immunity?
Yeah, that's a beautiful question, but I don't know any data. I think certainly well, there's no things that I know that you can do. There's things that you shouldn't do. You shouldn't get diabetes, things like that. But you shouldn't take immunosuppressants. I don't know that there's any things that you should do. I mean, this is the idea of adjuvant.
Correct.
Or maybe adjuvant in the next era of vaccines will be. The answer is no. I don't know. There's nothing I could recommend people to do other than to be healthy in general.
Do you know of anybody doing research on that currently?
Not on COVID. I think no, not on COVID, but it's a great area. It's very good.
If you become aware of something, please let us know, and then we'll research it with them as well. Moving on. Thank you very much, Commissioner Grimick.
Yeah, thank you, and thank you for the presentation. It was great, and I believe very timely as we are about to come out of our California lockdown here and open more things up. So I think it's beneficial for people to understand kind of what we're looking at. One question I have, and I've been trying to get the answer, I want to see if you know, is SARS-CoV-2, is it a latent virus where, much like chickenpox or something along those lines, they can lay dormant in the body forever, that you're kind of stuck with, and it can reappear as your immune system dips? From what I can tell, obviously this is an RNA virus, not a DNA virus. DNA viruses tend to be more latent than not. So I'm not sure if this has any of those properties. I haven't been able to get a definitive answer one way or the other, so I was just curious if you knew.
Well, these are all great questions. I've seen no data that these are recurrent or latent infections. In fact, this is very different than things like, let's say, hepatitis B. Hepatitis B takes a really long time to kick in. It takes just a long time for it to replicate and so on. So you can have antibodies that take a while and they work. This is an acute infection. And in fact, people don't get over it and come back with it that I've ever seen. Now, there was a really interesting study from a terrific researcher at Rockefeller University in Nature about 6 months ago or so, where he found that there was still viral antigen in our gut 6 months after COVID-19. And actually, this was good news because this allowed B cells, they need antigen to kind of get better and better. This allowed them to get better. So those were not necessarily active viruses, they're just viral antigens. So the body was clinging onto it to show to its B cells. So I don't think anyone considers this a latent or recurrent infection.
Okay, great, thank you.
Commissioner Hisserick.
Yes, thank you. This may not be a great question, but I just need some clarification. The vaccines that we've heard most about use the mRNA technology. I believe that some of them, the Johnson & Johnson, for example, uses what I guess would be more conventional type of vaccination. What's the distinction, and how does that fit into the descriptions you've given here?
Yeah, that is a great question. So this is the first RNA vaccine that's ever been approved in humans. It makes me nervous because we don't know how long it's going to last. So the old vaccines were actually neither of that. The old vaccines were just a peptide. Like you get a diphtheria vaccine, measles, many of those, they just give you a protein and your body responds to it. Now, they're also the most famous vaccines, the ones that really worked, were an attenuated virus. There are viruses that replicated in your body, they just didn't cause trouble, like yellow fever or smallpox, was the cowpox. That was the greatest discovery in medical history 200 years ago. That a cowpox, which is like an analogy, it's a zoonotic, sort of like this one was, but it doesn't cause disease. You give a cowpox virus and you become resistant to smallpox, but that's a replicating virus. A replicating virus gets into cells, the T cells get engaged, there's a lot of antigen everywhere. So the reason the RNA viruses were so attractive is that they get into cells. It's not just like giving a peptide, so that if they get into cells, that's the only way to get engaged T cells. And everybody recognizes T cells. So this is like a whole new space age kind of technology, and I do worry. Now, the influenza vectored viruses, I thought they would be better, personally. I thought they would be better because they, you put like a protein into a flu virus that's harmless. The flu virus replicates. The body thinks it's a replicating virus. It's all hands on deck. But so far I think the data have been, maybe just this one, but they haven't been as good. I think that we're lucky that these RNA viruses have worked so well, and I don't think maybe that they're the best ultimate technology, but they were the fastest. This is all guessing right now.
Thank you.
But let me just,
So if Matt and John, if you don't mind, unless you have another question, could you lower your hand? And then City Attorney Vaughn, you have a question.
Yes, thank you. I keep reading or hearing about researchers, whether it's Weizmann Institute for Science or other organizations that are looking at a vaccine that takes care of all coronaviruses. And I'm not sure if you've heard about that research, what you think about that research, but I've heard a couple times that there are researchers working on that. I don't know if they're in trials yet, but I don't know if you knew anything about that, or if you even think that would work.
I think that's doable. I think, I do worry. Look, we've had 3 very serious coronavirus diseases in the last 20 years, after everyone thought it was just common cold. So it's not like this has never, hard to believe this will never happen again, to be double negative. And there are shared parts of all coronavirus. That's why the T cells seem to be cross-reactive, because there are shared proteins that don't like to mutate. Now, the RBD protein, the spike protein, likes to mutate. It's very good. It mutates like crazy. And it mutates because that's how you survive the antibodies, which are mostly against getting into cells. So I think that's a great idea. I haven't really seen any clinical trials. And if they could pull that off, that would be, to me, the next generation. I think the next generation vaccine will be long-lived and broad. And broad could mean many coronaviruses. Yeah, that would be great.
Wonderful. Any other commissioners have a question?
If not, I have one more thought I forgot to bring up at the end here.
Please, yeah.
Okay, so in terms of how do we monitor them next year? I think we kind of in this little lucky lull or lag phase where things are good. People are going to go back. Sure, we're concerned about mutants arising from other countries as well. But how are we? I think a lot about how are we going to know if how well we're doing. I don't know what your commission has as far as the capacity to do this, but I would think that if someone were to see, what is the trajectory, what is the future going to be over the next 6 months or so, what might work would be to follow 2 things. First would be to take a bunch of people, 100 people or not even, and follow their titers in LA. Let's just say you did that. Not hard to do. You can draw blood every 3 months, every 6 months with a bunch of people. And see how fast they're falling. This is actually, all we have after the vaccine is like 6 months. So that's the first question. That initial fall was pretty steep. Is it going to flatten out, or is it going to stay steep like that? If it stays steep, we have a problem. We're going to either have to give boosters, which that's the problem, or we're going to have to deal with mutants. So the second thing is if someone were able to, in a fairly systematic way, monitor different demographic groups, different disease groups, and so on, different clinical risk groups, and how fast they're falling, then also look at the status of mutations. And everybody's worried about mutations, but in California or maybe in the U.S., are there mutations that are becoming more and more resistant to our antibodies? And it's that confluence that it's going if you have one slope going down and one slope going up, when those cross, that's when we're going to start having another crisis, in my opinion. So I haven't seen anybody talk about doing that, but to me that would be a proactive, preventative public health approach to monitor those 2 trajectories and see, are we going to be faced with a serious problem, and we go into another version of a lockdown in 6 months, 7 months, 2 years.
I think that those are wonderful things to study. The question would be, what would be the number of individuals? You know, is the N 100, is N 1,000, or 5,000?
Yeah, I don't know. I think people could do those calculations. You have great people in the survey, yes, I think that's a good question. But to me, it's not going to be a big number. I mean, we have studies now which are considered pretty definitive, and they have 1,000 people followed up for 6 months. But I think that's probably even more than
It might be something that we could look into and potentially have the county and or some of the other individuals who are looking at. We actually have relationships with people who are looking at the mutation, the DNA analysis, RNA analysis of the variation of the virus, and also we have epidemiologists who could potentially help us as well. So the issue that always happens for any research program is where the funding comes from, and we're a political body, so we don't have access to funds. We have to go through the city council. But there are other groups here in Los Angeles that probably have a better ability to get funding than we are. But we can appeal to them. A wonderful idea. Thank you. Any other commissioners with a question? Seeing none, Professor Hellenstein, we're thrilled that you came. You're welcome to stay on if you'd want to hear any of the other talks. We also realize that you're extremely busy. We will not take it personal if you sign off. We're honored that you would come to be with us today. And seeing no other commissioners with a question, we'll move on to agenda item number 2.
Thank you very much. I appreciate it.
Appreciate it. Thank you very much. So agenda item number 2, we're lucky to have with us Anders Corey and Anthony Cepetis. Correct me if I'm destroying your names, I apologize, who are from the LA County Department of Mental Health Services, and they're going to talk about mental health and support for students in the LA city and LA County. Gentlemen, which one of you guys are going to go first?
Anders, I don't think your mic is working, but Anders should be going first. While he gets that up and running, hi everyone, my name is Anthony Cepetis. I am the Health Deputy for Supervisor Solis, so representing Supervisorial District Number 1, and Anders over there is Health Deputy for Supervisor Barger.
Is it working now?
It is. I'll let you take it away.
Thank you for the introduction, Anthony, and thanks for joining us. And we're partnering here today, Supervisor Barger and Supervisor Solis, led by Supervisor Solis about a month ago or so, brought forward a motion to the County Board of Supervisors to really evaluate how the county could better engage and more thoughtfully and proactively engage in mental health services in our schools. Obviously, the concept of increasing mental health challenges through COVID is not foreign to anybody, especially that those the increasing rates of mental health challenges amongst our youth were isolated for most parts of the last year, and we're on top of that experiencing hindered academic, social, behavioral development at the same time. So this is really on the front of mind for us. And I think we also viewed it as an opportunity to reshape how we approach mental health services and the topic of mental health conversations in our schools, with students being gone for nearly 18 months at this point. By the time we return in the fall, it'll be more than that. This is an opportunity to really engage them at a different level and make sure that we're really doubling, tripling down on the opportunities to not only provide services, but have the conversations about mental health. And definitely know that when they return, there's going to be a greater need for making sure that there's not only services on site, but better training amongst staff and faculty. And so I'll go into a little bit of background on the role of LA County, where we fit in providing mental health services and what services are being provided on campus, and then really want to leave time for questions of clarity of where the commission feels like they want to be involved, and any specific points that we didn't hit on. It's a very broad topic, so I want to make sure that we allow for time for questions from you guys. So the County Department of Mental Health works in collaboration with local school districts, the County Office of Education, and many public-private partnerships we have with local organizations, think tanks, universities, etc., to provide our mental health, to ensure mental health services are available in schools. Now, for direct services in schools, each school district gets direct funding from the state to provide their own mental health services. So the primary mental health services in schools is provided by the school district through funding from the state. So the county plays a role. The county builds relationships between providers and contractors, nonprofits with the schools, but it is really the primary responsibility of the districts to ensure these services are available in schools. But from there, where the county plays a really a linchpin integrated role in ensuring those services are available, and then also taking a broader look at what's being offered and how we can potentially invest in it further. So many schools contract with the county or county-provided contractors to bring their mental health services on site. The county helps to facilitate a lot of those relationships, and many of the contractors that our schools, or many of the providers that schools contract with, are existing contractors of our department, which we invest in, we support, we fund, we train. It's a very collaborative process. But the county is always identifying different ways where what the existing school resources the district have is going towards, where those are insufficient, we're trying to find ways where we can come alongside the districts and augment what they're doing. So one thing that we do all the time is we're always distributing training materials and resources for schools and to help with providers. So we're preparing a lot of general resources for parents, for students, for teachers, for administrators about how they can better advance the conversation around mental health and also provide services in the moment. So these are more generalized resources that can be applied by all people, not just clinicians, but that help, we believe, break down the barriers of the conversation of mental health in schools isn't just confined to the clinician on site or the contracted service provider, but with all involved. We believe it needs to be all parties involved, students, parents, teachers, administrators, talking about mental health. And we develop specific programming for students. We're developing some specific programming as students return to the classroom this fall that is targeted at not only general adolescent mental health challenges, but also the challenges that we've seen come into play with students as they've been gone for 18 months. The Department of Mental Health also specifically does training for educators, specific mental health training that equips them to better engage with those conversations with their students and to understand different mental health challenges that may be arising that if they weren't trained, they would not notice on. I believe it's only about 50% of youth in general are actually diagnosed for the mental illness that they have or suffer from. So part of this training is to educate teachers on how they can better engage with students and understand which mental health challenges they may be exhibiting. And I think we've trained over 1,000 educators in LA County, in schools in LA County overall. So it's still something we're pushing out there and it's made widely available. We're also establishing an ambassador network to promote mental health awareness in schools that's bringing on teachers and students to promote access to resources and services. We're preparing a toolkit for schools to utilize that kind of what I touched on before, how we can bring students back to campus. What do teachers need to be aware of their students were facing over the last year, and how can they provide a place in a classroom that is welcoming but also cognizant of the fact that many of the students had a traumatic last 18 months. The last big thing that I want to make sure we hit on that we talk about, which I think is the flagship of our mental health resources, is in 2019, the Department of Mental Health started a community schools initiative, which was pretty much doubling down on the existing mental health resources in these schools. So the pilot started in 2019 with 15 schools, and for all intents and purposes, it provided another set of mental health resources on campus. It provided a full-time program specialist, full-time clinical staff, and full-time educational community worker whose job was to engage parents with the mental health resources on schools. So it's both clinical and engagement, 2 full-time staff at each of the 15 schools to really identify the needs of that community and then also to provide additional clinical staff. So we're currently identifying funding to expand this to 25 schools, and this has been targeted based off schools where we identify either additional resources were needed or they had a higher rate of students experiencing mental illness. But this is really where we, it's a very intensive program, and requires a good amount of funding. But we're really proud of it, and it's been very effective, and we're really excited to expand it just to really provide way more additional resources in these schools that are of the highest need, and ensure that we're, identifying these challenges very early on. So those are the high-level views of kind of what the county's doing in schools, how we are engaging, how we're supporting. Anthony, is there anything that I failed to touch on that you think is worth mentioning?
Well, that was quite comprehensive. I think the only things I would add to what Anders presented is that some of the things that we're working on now is trying to figure out the limits of, where DMH picks up, where the schools leave off. And I think that the best way to kind of envision it is that the schools essentially are the first responder, the first provider for mild to moderate services. And where DMH and the county step in is, as Anders said, those supports, providing those resources, those school toolkits, making sure that the schools are supported and have what they need, and also providing that specialty care. So it's for us about approaching the schools and the districts and letting them know that we're a partner, and we have these resources available at our disposal that can help them address some of these challenges. And as we know, there's 80-plus school districts across the county, over 2,200 schools. Not everyone is going to be equipped to respond to these types of crises and the traumas that these students are going to be facing equally. So it's letting them know that we are here as a resource, putting ourselves out there and offering these toolkits, online resources, triaging, and providing specialty services to the students who need it. As Anders said, it is really concerning that about 50% of youth who have a mental health illness or some sort of it needs to be addressed go unidentified, especially when it's been estimated that about 1 in 6 kids have some sort of mental health illness that needs to be addressed. So that's a pretty big part of the population there. But otherwise, Anders covered everything, and happy to answer any questions you might have with respect to this or the motion that our boss has put together. Thank you.
So I'll take the privilege of the chair and ask you a bunch of questions. Either one of you can answer, or both you can. So you should be aware that a year ago we actually had presentations from experts on pediatrics in regards to health and schools being open. And the biggest concern that we had in July of last year, 12 months ago, was specifically the mental health needs that were predictable from closing schools and what would happen. And we had another presentation several months ago that actually showed from Children's Hospital all the data in LA County of the increased amount of problems that is being seen by the hospital clinics that are dealing with adolescents primarily, but even younger kids as well. And so we applaud you and the supervisors for addressing this issue. I would say that it was somewhat predictable that it would happen from closing schools for as long as we did. And I think we can learn from that going forward if there's another increase in the numbers or the incidence of the disease within the county, that we should maybe be cautious because of the problems with mental health. Nationwide, the number of teen suicides is up 40%. The number of, unfortunately, body image issues is up by 60%, and the amount of mental health crises, as you know, is up between 40 and 50% in kids between the ages of 6 and 21, the adolescent age groups. Clearly, that's the groups that you're addressing. And so we applaud what you're doing, but I would just beg you to let the supervisors know that we are fearful that if there is further lockdowns of the schools, that we're going to actually worsen the impact on those populations, the younger kids, elementary school kids, as well as the secondary school kids as well. In that if there's going to be some lockdowns that we have to put in our equation something that looks at the impact per capita of hospitalization, long-term issues in regards to body image issues and or suicide, all of which we didn't really address the way maybe we should have 12 months ago or 10 months ago. So the question I have is, what plans does the county now have to going forward if there's an increase in the incidence of COVID-19, if we get a third wave, to respond so that we maybe protect our kids better than we did before?
Yeah, I mean, that's definitely the question that's in the back of everybody's mind is, things are great now, but what happens if/when there's an increase? I think many people expect that combination of many things as we get to later in fall, that some kind of increase is more likely than not. I think our most likely assumption, and Anthony, feel free to chime in on this, is we're still kind of at the tip of the iceberg on this one, is that given our high levels of vaccination, even if there is an increase, it's not going to be the point where it threatens our healthcare system so critically that we'll need to shut everything down. I think that's the most likely situation, is that there's a moderate increase where we may have to bring some controls back in and some measures, but it will not be the point where everything needs to be shut down. So I don't think we're expecting a place where it's like last fall through winter, where it's complete lockdown. But I think it's going to be a sliding scale. Regardless, I think you're right that was a lot that we could have done, and I know our schools and our school districts and our Department of Mental Health have written extensively about, if we'd known this going into it, we would have done X, Y, Z differently. If we were in that situation where there was a lockdown, there would be a lot more proactive engagement with our students, a lot more on the ground, getting out into the community in other ways, because we know that in-person connection was the most critical part. But it's a moving target. Anthony, is there anything else you want to add onto that?
No, I very much echo what Anders had to say. I think that the general assumption right now, and as he said, we are in the early stages, is that the worst is behind us essentially, and that if there is some sort of surge, it'll be moderate to mild, which hopefully could then be contained via your regular public health protocols, like your testing, contact tracing, what have you. And I think that, we've had some encouraging data, at least. We've seen that as we've eased restrictions and health measures, gone from purple to red to orange to yellow, and opened up more opportunities, we haven't seen a corresponding increase in our cases. In fact, our cases have continued to decline across all sectors, which I think really speaks to the strength and efficacy of the vaccines, existing levels of immunity in the community. And I think, the previous speaker would probably highlight essentially what the long-term ramifications of that may be, but at least I think there's good data to suggest that for about a year that these things are effective. And we also are anticipating that sometime in the fall, Pfizer and likely Moderna will have some sort of authorization for students, younger kids from the age of 5 and above. And as we start to get those vaccinations, hopefully that would make it safer within the school environment and would prevent that type of spread. But as I said, this is all purely conjecture at this point, but that's kind of what we're looking at.
The other thing is that we have one of the most diverse counties in America in demographics, but also in hospital beds and things of that nature. So, for example, looking at kids in West Los Angeles, we have Children's Hospital of Los Angeles is one of the best hospitals for kids in America. You have Mattel Children's at UCLA, you have Cedars. We have a lot of capacity. Huntington Memorial also has some capacity for kids. If you go up to Antelope Valley, not as much. And so I think that addressing the pediatric population, we have to have different protocols for communities that have less beds available, or alternatively have programs involved where the leading experts at our Children's Hospital can do telemedicine to the adult ICU doctors who can handle, say, a teenager and or somebody up to the age of 25 or 30, which is not that much different from a 21-year-old is not that much different from a 26-year-old. But then have a pediatric specialist who does pediatric ICU medicine, because there are some subtle differences. looking over their shoulders, and we can do that by telemedicine or communications. We just need to have a system in place to beforehand, if that third wave in fact comes and is worse, and not necessarily for just this virus, the kind of program we should have, potentially, going forward for all. So hopefully you guys can take that back to the supervisors. The other question I had is the CARES Act gave a lot of extra money to the county. I'm not sure if it went to the Department of Mental Health. I know that normally the Department of Public Health normally has approximately like a $990 million budget on a good year. Is what they had the year prior to the pandemic. And I think they got another $250 million from the CARES Act, mostly going to the Department of Public Health. Did the Department of Mental Health get funds from that, or is there a way that some of the monies that came in from the feds for the CARE Act that went to the Department of Public Health or to the hospital system can cross over now that we're doing so much better, so that you guys have the abilities to expand some of those wonderful programs that you're talking about?
Yeah, so the funding that went to the Department of Public Health is pretty much locked in that COVID response safe. However, the county got $1.9 billion in general funds to address responses to COVID, and the board is in the final stages of finalizing where that funding is going to be allocated, and mental health is a massive priority from it. You're definitely going to see a pretty significant expansion in mental health services across the board, both doubling down on things that are already working that we have, and then also expanding the programs that we wanted to build into. So the answer is yes.
Wonderful. And then, if I can, a total tangent that's peripherally related to what we're talking about, but is very timely, and being that we're honored to have two health deputies, which is a luxury for us to have you both here, and we're really thrilled that you're both here, is the old LA County hospital that was closed and is a landmark building, so it can't be taken down, has been or is proposed to be developed to address mental health issues, among many other things. There's a homeless crisis in the city and county of Los Angeles. There's a lot of beds. That building is plumbed. It has electricity. It has the ability to handle, a pretty serious earthquake. It has food facilities in it, and as planned, has the ability to address mental health issues as well. Why have we not used that to more aggressively handle the homeless crisis? At one time, when the building was first built, the population of LA County was only 1.2 million. And it could handle 4,000 beds. We probably could house 5,000, 6,000 people there with support, mental health needs, and food and plumbing, so people could be sheltered. Is that being addressed at all?
I'm going to defer to Anthony on this one, seeing as that one's down in his neck. That's in your district, right, Anthony?
That it is. I was smiling here. I was like, wait a second. Someone's got to beat on my emails. So that's a great question, and I want to say very full disclosure, I'm neither on the planning team nor am I the homelessness deputy for our office. That said, I've worked with him and had conversations about this very subject. I should also, in the spirit of full disclosure, state that I joined the team about 4.5 months ago. So to the extent that I have the history of all of this, I'm still getting up to speed. So all of those grains of salt sprinkled in here. I will say that there are conversations of identifying various sites and locations for interim housing, temporary or permanent supportive housing. Old General Hospital, of course, has a lot of beds, but I think that, we've also done some site analyses and looked at what it would take to actually, there's a lot of upkeep and refurbishing that has to happen in order to make that building livable. That said, it hasn't been ruled out, but I can't speak to where it is in that conversation. But it's not, I can tell you that those conversations are ongoing, as well as a number of other potential solutions or locations to provide housing to folks. And I know Anders has been very involved in those conversations as well. So he can speak more to the general approach to persons experiencing homelessness. But I do take your point.
Yeah, your point was on the right track. We're evaluating every space that we have that we can potentially utilize. And on one hand, it's a fine line between where a lot of these places need refurbishment, but at the same time, it's better to be alternative than many of the folks on our street are facing at the same time. So that's what we're weighing here at the county and doing it at a very meticulous level, site by site. So it's definitely on the frame of being considered, and we knew that there's a lot of capital funding that came through this recent federal relief package to the state that we're hoping will come down to invest in projects like that.
And I didn't mean to, I apologize for blindsiding you on that. It was just, it's so timely with the problems of the homelessness. And the other thing is that the buildings, was used as a full-service hospital just, 6.5 years ago. And so I recognize from a capital point of view or from another aspect of things, it's not perfect. We're talking about interim housing, and we're not necessarily talking about anything that's going to be 5-star. It beats sleeping in a tent or under the stars or underneath a freeway off-ramp. So, I would advocate that the full steam ahead. You get as many people off the streets as possible, and from a mental health point of view and from a physiologic point of view, it's going to be better and save us money in the long run and be better for the mental health of those individuals. But other commissioners have questions, please raise your hand so I can see. Commissioner Hisserick, your hand's up.
Yes, it is. I just wanted to ask the gentleman that when they intervene in the schools, is it all done by Department of Mental Health personnel, or do they contract with private agencies like D.D. Hirsch or San Fernando Valley Community Mental Health Center or something like that to provide the intervention?
Yeah, so each school and school district contracts with mental health care providers, many of whom specialize in pediatric mental health. Now, obviously, if there's acute mental health emergencies and our emergency line is called, occasionally our Department of Mental Health team is involved there, but the primary first response is with contracted providers that they work with.
The school district is arranged, all right.
Yeah, the way the state provides school-based mental health services is they fund the districts primarily, and then the districts go out and contract for those services or provide them themselves.
I see. Okay, thank you.
You bet.
That said, if I may add, there is a role for the county to play here, and that was part of the motion that our bosses helped put forward, and that DMH has quite an extensive network of legal entity providers that are available throughout the county, many of which the schools aren't connected to at all. So part of the motion and part of what we're trying to do here is making sure that the schools and the districts are aware of the DMH services that are available in close proximity, or that they can send and refer students to should the need arise. So we're definitely looking at that from our end as well.
Thank you.
Any other commissioners with questions? Seeing none, I'll come up with another question then. Just we're so lucky to have you guys. A concern that some people have is the number of staff of the school systems that refuse to get vaccinated, and the impact that might have on kids, and also when in a non-COVID year, about 52% of students don't get vaccinated for the flu, which is a disease that we know actually hospitalizes and hurts kids, as opposed to this one, which much less impact in regards to hospitalization incidents. Is there money from the county available to study the numbers of people epidemiologically who either refuse to get vaccinated or for whatever reason have not had the ability to get vaccinated, both from a staff point of view and also from a student point of view?
Like, run the data for each district and identify how many students and staff in each school or school district are vaccinated or not going to be vaccinated?
I wouldn't say each district, because as you know, there's 80 whatever districts. I think we could do one from each supervisory district to be fair to entire county. clearly there's some demographic differences in each of the supervisory districts, but so that we can get some data. Anne Ramoyne, who's a leading expert on epidemiology and a professor at UCLA, actually has a study that she's been trying to get funded, and we've helped her get some funds for that with LAUSD, but she could expand that easily to other school districts just with some funding. That we've had some hard times. She's had some hard time trying to get funding. She's got PhD and also postdoctoral support, and she's got the whole process all ready to go. It's very easily expandable if there's some funding available.
And we have, obviously this is different. We obviously have targeted vaccination efforts based off of neighborhoods and zip codes with lower vaccination rates than others. So that gives us an idea. I think this hasn't been explicitly discussed. Maybe this is an opportunity to look further into it. But we do know that schools being major touch points for health access, that as we get closer to coming back to school, we expect to see another wave of people being vaccinated that may not have been vaccinated before. And we'll absolutely be targeting our outreach in areas where we know those are lower, so maybe some data like this could help support and target those services. Anthony, do you have anything else to add on that?
Yeah, I don't know that we have any data or any surveys out there specifically targeted hesitancy in the school environment for COVID vaccines. That said, I know that Anders and I were on a call earlier today with public health talking about what initiatives they have in place to continue to get the pulse of community, especially those who have not gotten the vaccine thus far. And, we're told that there's ongoing focus groups, there's polling that's conducted with partners of DPH. It happens regularly. And the understanding is generally the same that we've heard for the last month, that a lot of folks still want to wait and see, want to make sure there's more time in this, more time behind the vaccines to make sure they're safe. That said, we're doing whatever we can to be creative and reach out to as many folks as possible, encourage the vaccination. We do already have many, many vaccination sites directly located on school campuses, and as Anders said, we do anticipate that as students start returning to the school environment, we'll see an uptick in vaccinations at that point as well.
Thank you. That's wonderful. As long as I have two of the five health deputies, I'll ask you another question that we've actually addressed at the LA City Health Commission 3 years ago and have not previously gotten an answer, but maybe you guys could think about it. Is currently when you look at the spas, your spas overlap supervisory districts. They're not all contained. And I realize that there's 5 supervisors and there's a different number of spas. So either create 10, so there's 2 in each district, so you can break it up so that you guys can have better impact, and there can be some reliance that each supervisor really has the data available for her or his district. But to me, when there's a split district or a split spa through 2 supervisory districts, it's hard for you guys to get the data you really need to do it. I realized when spas were created years ago, the world was different, but now with supercomputers, you can get down to zip code data, and there's no reason why you shouldn't have the most up-to-date data. We all would have been better off as the pandemic hit us if we had better data available to use, so you guys could give the best advice you can to the supervisors who I know are trying to do their best to handle this unfortunate situation that we've been in. So on behalf of the commission, I'll overstep the other commissioners and just say that we discussed this 3 years ago and kind of sent it up the food chain to you guys and, never got an answer. So you don't have to give us an answer today, but maybe take that back to the supervisors in your planning that there needs to be accountability to our elected officials, and their jobs would be better, your jobs would be easier if you had data that was more specific to the individual districts that you represent. So seeing no other commissioners, I truly appreciate you guys coming today. I appreciate your dedication to the people of LA County, your knowledge and the wisdom that you give our supervisors. The city is separate, but we're hand in glove with you guys, and we truly appreciate this. And we would hope that you come back and allow us the ability to reach out to you, even not necessarily at a commission meeting, but in other areas where we could keep the lines of communication open. You guys do a great service, and you don't get thanked enough. So on behalf of the LA City Health Commission and in behalf of the entire population of the city of Los Angeles, I applaud you for the hard work and dedication that you guys give. It's truly appreciated, and you really help 10.2 million people, and we see it, and we appreciate that. Thank you.
Well, thank you for having us, and appreciate the opportunity to talk about this really important issue. And of course, as you guys go back to your communities, if you see opportunities where we could potentially expand access, or there's not proper or adequate mental health services being available in schools to our students, please don't hesitate to reach out again. We provide an augmenting role to support what already exists, and so however way we can influence that or reinforce that, that's our lane. So we always love to hear that, so please don't hesitate to reach out.
Thank you. And then same thing I said to Professor Hellerstein, you're welcome to stay on. We recognize how hard you're working. We also recognize the time of the evening is and you have a long day. We will not take it personal if you sign off for the rest of our agenda. But we're really, truly honored that you've come and give your time to us and give us the wisdom and all the work you're doing to help the students of Los Angeles County. Thank you.
Thanks for having us. Really appreciate it.
Yes, take care.
Thanks. Moving on to the third agenda item, we're going to have a brief introduction from doctors, and correct me if I mispronounce your names, not one of my strong suits, but Jin Yang, Dr. Jin Yang and Dr. Tanya Kondalai are going to do a research project looking at homelessness and health and mental health within the city and county of Los Angeles. And they're going to work with us, Health Commission, in a research analysis as well as hopefully a paper. Doctors, the floor is yours.
Jin Yang, and my colleague is Tanya Kondalai. I'd just like to introduce a project that we are working on. We're working closely with Dr. Mendel and Commissioner Sirota on this. We're conducting a study to analyze the access to medical and mental health care of the homeless population in the city of Los Angeles. As we all know, and as Dr. Mendel mentioned, there is a homeless crisis. In recent years, the number of the homeless population have been steadily increasing. Our study will look into various aspects, including what resources are available for the homeless population, how they are being informed about available resources, and challenges that they may face in accessing those resources. We're in the early stages of the study, which will be completed in August. But we'd appreciate any input from the commissioners as well as any guidance towards any resources that may provide insight on this topic. Now I'll hand it over to my colleague, Tanya Kondalai. Thank you.
Hi, good evening, everyone. My name is Tanya Kondalai, and like my colleague, Dr. Yang, we are actually completing our Master's of Public Health degree because we feel like it complements the medical degree, and so that we can help the community on more of a population level as opposed to just the patient coming into the clinic or the hospital. With research, we saw that with reports, there's a projected, the homelessness in LA County is supposed to skyrocket about 86% within the next 4 years. And I know that we talked about the vaccinations, and we are currently in a global pandemic with coronavirus. And so we're not sure of how the next wave would come or if, even another infectious outbreak would occur. So we feel that it's imperative that the vulnerable populations, especially the homeless, are protected and can also help to curb the infection rate too. And so to reiterate what Dr. Yang was saying was that our study will look into various aspects of the utilization and access of healthcare resources by the homeless population. And we would like to thank you for including us today in the agenda. We are very grateful. And if anyone has any guidance or resources that may help with this project, we would appreciate it. And I know that when Anthony and Anders were speaking earlier, I think Dr. Mendel had already asked the question that I was thinking as well, that with the hospital, and they were talking about how it needs to be refurbished, but I was thinking along the lines of with the interim housing. I wanted to ask what they meant by refurbishing and how much cost that would be to LA, because I thought a similar thing that, you know, maybe that building, maybe if it's not the best, you know, for them, but it's probably much better than being on the street. And especially with the homelessness right now is, you know, it's grown substantially over the years in LA, and it might be safer for even people that are not homeless and just living within. And with the coronavirus, that maybe if the hospital could be open to help that. That was just a thought I had too. And I know that as you were asking, I wasn't sure if I was allowed to talk, but then I was like, well, you answered that. You were asking the question that I thought too.
Do any of the commissioners have a question for either Dr. Yang or Dr. Kondalai? Commissioner Shannon.
Hi, sorry, I'm a little backlit here. Well, first of all, I just want to applaud you for doing this project, for this report and study. I would say that it's somebody who has worked with our unhoused population since 2005. It's really, really important to get, you know, to hear directly from people who are unhoused on what barriers they're facing. And I'm sure you're planning to do that. But I know that a lot of times people will go to stakeholders or executive directors of nonprofits. The people who know probably the most about the barriers that they're experiencing are our unhoused community. And I'm, you know, happy to connect you with some folks that I'm working with who live on the street currently. But I would also, if you haven't gone through our archives for the Health Commission, we did actually, I know when I was president of the commission, we did actually do a hearing on this where we had some folks come and speak. I think it was, you know, mainly from a sort of community clinic angle about, you know, some of these barriers that people are facing. And there, you know, we didn't have anyone speak from our unhoused community, but it might be worth listening to. I can't remember exactly what month that was. It was likely like 2016 or 2017. But it might be worthwhile just to get, you know, an overall idea of some of what people are facing. Particularly just, you know, even having to leave your stuff out on the street when you go for a doctor's appointment can be a challenge because your stuff could get stolen. It's just like all these little things that we might not think of as people who are housed, but, you know, things that our unhoused community like to face every day and the decisions that they have to make, which is a trade-off for their health care.
Thank you, Susie, for sharing that, especially with the point that you said about where would they leave their things if they go to the doctors. I never thought about that. And that might be something that is quite a concern because if they leave it somewhere, then somebody else might pick up their things, right? So thank you for mentioning that.
Yes, and thank you so much. We really appreciate it. And we'd love to speak with your clients and just interview them to see what their situation is like as well. And we'll definitely go through the archives. Thank you.
So if the city clerk's office can send out to all the commissioners Dr. Yang's and Dr. Kondalai's contact information in case they have thoughts, ideas, questions, or resources that could improve the study, research study, that would be appreciated. I think that we could do that without a vote. I think we just, we can send that out to people and make it easier. And for all the commissioners, now you can put a face to the name, and I think that's an important thing. And go from there. Commissioner Hisserick, you have a question. John, I think you're muted.
The acting. There it is. Finally got it up. I just wanted to know that if you've been in contact with the emergency medical services folks, both with the fire department and potentially with others, because unfortunately that's the agency or the entity that often comes in contact with unhoused people in terms of their medical concerns. And they do a lot of that. And I just wondered if, you know, the city fire department has, through Dr. Mark Eckstein, who's their medical director, and others, and through the county as well, although they use private ambulances, they do have the fire squads that go and interact with folks. So it is a source of sort of on-the-street information about how unhoused folks get their health care. So just a thought.
Thank you, John, for bringing that up. Actually, Ying and myself, we spoke last night, and that was actually something that I was thinking about as well. But I had, Dr. Yang had said fire department, and I was thinking the LAPD with the emergency department, because I thought that, well, I'm from British Columbia in Vancouver, and in downtown Vancouver, there's there's a growing population of the homeless as well. And I know that the police department kind of helps kind of track that area, and I feel like they may know more things about what's going on the streets. So to get like a more comprehensive viewpoint, I was thinking that if we could look at other areas, like you suggested, the fire department, the emergency department, and I wanted to see if we could include the LAPD too, to kind of see how different aspects of how other people are interacting and what information they may have about the homeless, because I feel like that might give a bigger picture of what is going on, and maybe get a better idea of how they could get better access to healthcare and how they're actually using it.
Well, the LA City Fire Department has gradually increased their capacity to deal with these things. They have, for example, for folks that have an alcohol problem, they have a drying out center. They also have circumstances in which nurse practitioners or physician assistants respond and assist. So they're pretty much in touch with the healthcare needs of the folks on the street. Now, it's not to say that obviously the police department sees them as well, but the healthcare is rendered typically by the firefighters. In the county of Los Angeles, which of course surrounds us, there the fire department squads have the paramedics. They don't typically transport. They have a private ambulance do it. But they still are in touch with the issue of their health needs of the folks on the street.
Okay.
But I think it'd be helpful.
Okay.
Definitely, yes, thank you. We are actually hoping to get an interview with the medical director that you mentioned of the fire department. So we're going to work on that. And thank you for bringing up the emergency services.
Right. We can, our research associates can connect you to Dr. Eckstein. So you guys can write an email under my name. I give you permission to do that, introducing Dr. Zhang and Kandalai, and see if if he has some time to do a Zoom with them. And he'd be the best resource, even in regards to getting information in regards to law enforcement. He would have the information. And he's a great guy and very knowledgeable, and usually will bend over backwards to help inform us and for research purposes as well. He has an academic appointment as well. He's a good guy. He's very smart.
Okay, thank you. And for the emergency department, we did reach out to Sabin Clinic, and the lady's name was Anna Rowley, and she's just out of the office till end of June. But we were trying to, because the Sabin Clinic says that their community-free health clinic for the homeless is connected to emergency departments. with their clinic. So we could try to, when she comes back into the office at the end of June, we could maybe try to reconnect with her and see if she could help us get more information maybe between Sabin and the emergency department of the hospitals that they're affiliated with.
Sure. I think it's a good idea. Any other commissioners?
This is Ben. Sorry.
Yeah, go ahead, please. Ben, go ahead.
Yeah, this is Ben Pack. You can contact me for resources for LAPD. I'm a reserve officer with LAPD and very active. And I actually deal with the homeless population anytime I work, since I work Olympic. But, I can definitely connect you with the chief's office or the operations office as well, because they do have something called the HOPE team.
Okay.
And each division has dedicated officers providing services as well as resources to the homeless population. And each division also has the senior lead officers, and they're the ones who deal with the special issues and problems of each division. And as you know, there's 21 divisions throughout LA. So I can actually give you my cell number. Is 213.
Hey, Ben, we're the public hearing. I wouldn't do that. So why don't you have Erica get it and give it to the doctors, just because anybody in the city or county can listen to this. And
kind of forgot that, but
Right.
please contact me offline, and then I'll be more than happy to provide you with that information.
Thank you so
Thank-
much.
Yes,
thank you, Commissioner Pack. Yeah.
Yeah, thanks for that.
So everybody else, we'll send out their contact information. So if you have ideas or connections, ways you can help them do better research, we'd appreciate that. And doctors, thank you for coming to present today.
Thank you for having us.
Moving on to the fourth agenda item, just two other things that we've talked about beforehand, so not really new ideas, but one is the city attorney, Vaughn, should present to us briefly about social media. So that's an idea that we should do potentially maybe in July, if not in August. And the other thing is our election for officers. And we don't have to discuss it now, but if people have a desire to be an officer, please contact our research associates. Being the president, I have somewhat of a conflict of interest. I would put my name back up for re-election, but there might be people who want to run, and we're a democracy, so the way our commission works, it's an open forum with nomination. So if people want to be nominated, let the research associates know, please, and we can place on the agenda. If not, we probably should have an election either in July or August. And is there any comment on when people think we should have it? Susie, if you have a...
Yes. Well, I have two questions. One is, our next meeting falls during the summer recess for City Council and the committee meetings. So I wanted to know if our commission is having that meeting in July, given that I'm guessing a lot of staff will be going on vacation during the summer recess for council. I think that recess, the last meeting date is the 2nd. And then they come back, I think, the 27th. So I just wanted to ask that question. It may be that, the city clerk's office has a better handle on that. So I think maybe August would be better for having the election.
Anybody else want to comment on that?
I can confirm from the city clerk's office, yes, the city council is on recess during that time period in July, but the commission can meet at their own discretion, is my understanding, whether they want to meet or not in July. Just because council is in recess does not require the commission to be in recess.
So I would say that, you know, given that we're still in a pandemic, that we're coming out of it, there's a lot for us to learn, and I think we've had some great presentations. I think that we can move along, and we should have a meeting in July. Which Monday it is, to me, doesn't really make a difference. Obviously, we wouldn't want it right after the July 4th weekend, or whatever that's going to be this year. But I think right now we're always been second Mondays, right?
That's correct. The commission's next meeting would be Monday, July 12th at 6 p.m.
So I think that's far enough away from the July 4th holiday that I think we should keep that as scheduled, and we're already working on getting some great presentations. So I think we should do that. And then I think Commissioner Shannon might be correct. The election in August would be reasonable. I think our last election was in either August or September, so that would be consistent with our off-calendar fiscal year. So it's a year-by-year thing that works. But again, if people want to run for any of the offices, please let one of the research associates know. Seeing no other questions or any comments from any of the other commissioners? Can I have a motion for adjournment?
I make a motion to adjourn.
Is there a second?
I'll second, but I have a question.
Please.
If someone is out of town in July or August, is it possible to participate via one of these electronic participation means, depending on what the decisions are about hybrid or full participation and so on?
For now, Commissioner Hisrick, we're going to be Zooming through the fall.
So if I'm out of town, I could Zoom from wherever I am.
And hopefully, if you're at a beach with a drink with a little umbrella in it, we appreciate that.
Okay. All right. Thank you.
Anybody else have a comment? Seeing none, we have a motion with a second. All in favor of adjournment, say aye.
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 Any abstaining or any nays? Seeing none, we're adjourned. Everybody have a wonderful July 4th holiday, and stay safe. I appreciate everyone's efforts and all the commissioners for their volunteerism and altruism to help the people of the city of Los Angeles. It's truly appreciated. Thank you. I appreciate the city clerk, the city attorney, and all the support staff that allow us to have these meetings and make them so efficient. The people of Los Angeles, thank you all for your efforts. We truly appreciate it as well.
Not all. Thank you.